Good evening and welcome. My name is Ekene Enumchukwu. I'm the medical director of the Stanford Multidisciplinary Pelvic Health Center. I'm a urologist with fellowship training in urogynecology, male voiding dysfunction, and neurourology. This webinar is designed for both primary and specialty care practitioners. Tonight, we will address the assessment, management of common pelvic floor disorders, including pelvic pain, urinary incontinence, rectal prolapse, LGBTQ plus care, and male voiding dysfunction. Through short, high-yield didactics and interactive case discussions, you'll learn from pelvic floor specialists how to recognize, evaluate, and manage common pelvic floor disorders. So we have a very high-yield agenda lined up for you, so I'll go ahead and get started with a few housekeeping items. Many of us have participated in webinars over the last 2 years, but as a quick review, we just want to let you know that you should use the Q&A feature in Zoom for questions. So you'll see that down in this section here. And you can type in the question that you have and we will answer those. And then if you have any technical issues, then we ask you to use the chat feature for that. And our Stanford CME staff will assist you with that. So this is our agenda for the evening. So we're gonna go ahead and get started with some introductions, but we'll start with pelvic pain section and then a case and some Q&A for that section. And then we will have a LGBTQ health section where we'll also have a Q&A after that, short didactic, and then we'll round it out with rectal and pelvic prolapse and urinary incontinence section with, again, a case at the end of that with a Q&A. So before we get started, I want to again extend a warm welcome from the entire Pelvic Health Center team. This is the team that makes it all happen, from surgical subspecialties, medicine, radiology, and pelvic floor physical therapy. Really, to set the stage for tonight's webinar, I would be remiss if I didn't mention the current paradigm shift occurring around healthcare delivery. It's really important to note this shift from really disease-centered care to patient-centered care, where we're not defining patients by their diseases and kind of basing our management on strict treatment pathways and one-size-fits-all approaches, and really approaching the patient as an individual, relying on strong clinician-patient relationships and providing individualized care with multidisciplinary approaches when appropriate. So what makes our Pelvic Health Center unique is that rather than silos of subspecialties, we're really a full-time co-located clinic that allows us to care for the patient and not just a disease. And in order to avoid those silos of subspecialties, really try to approach our patients through these programs. For example, male voiding dysfunction, neurogastroenterology and neurourology, pelvic and rectal prolapse, pelvic pain, postpartum, genitourinary syndrome and menopause. And we also have monthly multidisciplinary case conferences to discuss complex patients. So without further ado, I am going to go ahead and jump in here and introduce our first speaker. This is our speakers tonight. I'll kind of introduce them as they come on. So our first one this evening is Dr. Diana Tashru. She's a clinical assistant professor in the Department of Obstetrics and Gynecology. She's also the director of minimally invasive gynecological surgery and pelvic pain center. Thank you, Diana.
All right, so the title of my talk today is going to be Who, What, and When, Bridging the Referral Gap for Chronic Pelvic Pain Management. So I have no financial disclosures, but I would like to disclose that for the purpose of this talk, I am going to be using she, her pronouns just for ease, but this is certainly not inclusive of the patients we see or who can be referred into the Pelvic Health Center, who might be female assigned, gender at birth, but identify differently and choose to use different pronouns. So the objective of my talk, I'm going to talk about, first of all, I'm going to give a brief overview on the epidemiology of chronic pelvic pain. I hope for you to understand the decision-making process to actually referring into gynecology at the Pelvic Health Center. I'm going to review the clinical steps in evaluating female pelvic pain from history, diagnosis, and physical exam briefly. I'm going to review treatment options from the pain perspective, and I'm going to highlight the comprehensive care model at the Pelvic Health Center. So just starting off with some basics, we know that pain is a common complaint among patients in the primary care center, but evaluating and managing pelvic pain inherently has its challenges. So as healthcare providers, we're not always the most well-equipped to confront the multifaceted, often vague nature of the complaints that patients present with chronic pelvic pain. The effects, unfortunately, for the patient, oh, did my pretest questions come through? Sorry about that. There were some pretest questions. We'll hopefully go over them later. The effects, unfortunately, for the patient is misdiagnosis or undiagnosis, not out of ill intent, but often lack of knowledge or resources. So we have to think of pelvic pain as a condition and not a disease, which we're going to review in the next coming slides. So pain, as you can see here, pain is often a cause for interventions such as surgery, which can be effective for some diagnoses, but for not all. And so you can see that a lot of patients walk away from the clinical setting, having gone through multiple medical treatments, maybe even surgical treatments, and they still don't quite have a diagnosis for their pain symptoms. So who is the chronic pain patient? So this is a patient who has pain in the pelvic region that usually lasts 6 months or more. This pain can either be continuous or it might even be intermittent. It can be dull or it can be sharp and cramping, and it can range from mild pain that's kind of annoying in nature, or it could be so intense that it interferes with work, sleep, exercise, and other normal activities of daily life. This pain is often non-responsive to medical or surgical therapy. And it especially might be bad during sexual intercourse or when these patients are performing certain activity, like having a bowel movement or sitting down. And these are patients that are appropriate to refer within gynecology at the Pelvic Health Center. So this is an example, maybe an extreme example, but this is an example of a typical pain patient that comes into our office that I might see at any time during her pain timeline. So she's had a long-standing history of pain that might have started years ago with a single symptom. In her case, it's dysmenorrhea or painful periods. But over the years, her symptoms have evolved and affected her overall functioning. And now, by the time she actually presents to the clinic, she's inundated with a variety of pain and non-painful symptoms. Now, this timeline really speaks to when to refer a patient to the pain clinic, or gynecology specifically within the Pelvic Health Center, and it could be anywhere in this timeline. It's appropriate to refer the patient when she's experiencing painful periods. It's appropriate to refer the patient maybe when she's experiencing other pain symptoms in addition to her painful period. But also, we also see patients that it's only one of the constellation of symptoms that they actually have. And so if you even suspect there's other multiple mechanisms involved, it's totally appropriate to refer this patient to the gynecology department within the Pelvic Health Center. So I put this slide up, and I think that you'll see this slide again. But this is a slide that talks about that chronic pelvic pain is often associated with other chronic overlapping pain syndromes. And there is really strong evidence to suggest that millions of people, particularly women, suffer simultaneously from multiple pain conditions that share similar disease mechanisms, mainly of the neurologic, endocrine, and immune systems, which are frequently associated with sleep, mood, fatigue, and cognitive disorders. So the data seems to suggest that the number of chronic overlapping pain syndromes, as it increases, so does the increased resistance to treatment effectiveness, reduced overall health and psychosocial outcomes, and diminished quality of life. And so oftentimes it's really important to identify these risk factors in patients and to consider that maybe, trying not to work in a silo. And if you see a patient with these other symptoms, it's not unreasonable to ask if there are other organ systems that might be involved as well. So these are kind of the guiding principles for comprehensive management. First of all, it's a history, and oftentimes I take about an hour to talk to all of my pain patients, and so they get that time with me. And I will say a majority of the time is spent on actually getting the history. I give patients a lot of time and room to talk and tell their story. And so, and then I do a physical exam. And the physical exam is a pretty comprehensive exam. It starts from even just visualizing the patient. You can tell a lot from a patient in just how they're sitting. Sometimes some patients stand up. Sometimes some patients are sitting on one side versus the other. And so part of the physical exam is observation, and then obviously a more comprehensive hands-on exam if I'm able to do that. Imaging can be part of the protocol, depending on what the patient presents with. And then we'll talk a little bit about therapies that can be offered. But really the goal of the pain visit is to characterize the pain or pains. And I'm really trying to evaluate if there are other multiple systems or organs involved. And so it's important to kind of see if there's other pain generators involved in their presenting pain symptom. We're also trying to identify or rule out central sensitization, because that could help us in terms of talking to patients about their therapeutic effects of the certain treatments that we can offer. And also a lot of time is spent on pain education. So we talk a lot about pain and how it can affect the patient from top to bottom and from bottom to top. And then we spend a lot of time prioritizing what is important to the patient. And then we review long-term expectations. So this pain visit initially is very comprehensive. And sometimes we don't get through everything on the first day. And I will have a patient come back if I feel like we need to go through things more piecemeal at a subsequent visit. So if the exam is benign, extensive imaging really does add little to the database. Interventions for chronic pelvic pain based on imaging studies alone is really unfruitful, but it can be used to rule out anything acute or any visceral sources of pain. So x-rays can be ordered to rule out any contributing spinal deformities. Ultrasounds can be very helpful and is often the first-line imaging modality used by gynecologists to rule out specific adnexal or uterine pathology, such as ovarian cysts. An MRI can be really helpful to look at the other visceral organs. And so it can be helpful to diagnose an adenomyosis and endometriosis, especially for preoperative planning. It should never be used as a standalone test to rule out endometriosis, and its efficacy can vary based on the location of the disease and the size of the lesion, but oftentimes I can use this modality as well. And if I'm concerned about a concomitant neuropathic condition, I will order an MR pelvis neurography as well. So if I think there's neurogenic pain. I mentioned the endoscopic ultrasound because it can also be good for endometriosis as well. So there are a variety of different things depending on what the patient has had in the past, or if I think that they've had suboptimal imaging, it'll help me make a diagnosis or rule out some things. I certainly can use imaging to help evaluate a pain patient. When it comes to treatment options, you can see here there's a plethora of options. So there's a variety of different treatment modalities that I can utilize, including orals, topicals, vaginal, and even interventions. And this can include hormonal therapy or nerve pain medicines, muscle relaxants, et cetera, as you can see here. Oftentimes I refer patients out to pelvic floor therapy, and I do these interventions, which can include surgery, but also not surgery as well. So treatment should really focus on not only treating the specific disease, but really it's important to reduce the overall pain experience. So as pain specialists, we really think of therapy within the framework of a biopsychosocial model. So there are non-pharmacologic and supportive care measures can also be prescribed to address the often somatic and psychologic contributors to pain, as you can see here, the variety of different agents. And oftentimes I will offer a multimodal approach to pain, and that might include things that are non-pharmacologic or pharmacologic agents, so the patient has a wide variety of things that they can use in their clinical toolbox. So the first line treatment often can vary based on specifically the exam, the history, and clinical findings, but as diagnoses emerge throughout their pain course, so do treatment strategies. And so when these fail, interventional therapies can be considered based on treatment responses, and obviously shared decision-making goes into this process as well. So just in general, as I'm sort of rounding up here, these are the diagnoses that I treat as within gynecology at the Pelvic Health Center. And this is just some of them, from vulvar pain to fibroids to adenomyosis. You can see the exhaustive list down here as well. If you're interested in referring a patient to the gynecology, to me within gynecology, you want to put an order in for gynecology at Pelvic Health Center, and then you want to put my name specifically on the referral, and that way the patient can get directly into my clinic. So it's also really important in general, and what I do a lot in my visits is really just managing expectations, that there is not going to be any instant result, that oftentimes this is a very prolonged this is a prolonged relationship I have with patients, and that I usually tell patients that it can take weeks to months for them to have any improvement in their treatments, that we usually reevaluate their symptoms, sometimes as soon as every 4 weeks, sometimes it's every couple of months, and we often have to times manage side effects to the therapies that they are given. So we always consider a multimodal approach to therapy, and this is going to maximize the treatment for pain and other comorbid conditions as well. We talk about additional pain medications if there's only a partial response or after a trial of therapy, and we often consider non-medical therapies and sometimes interventions depending on what the actual pain complaint is. Rarely surgery is actually needed for chronic pelvic pain. And so I always get these referrals for patients that come in for surgery evaluation, but oftentimes it is not that. We end up creating a treatment plan that is tailored to each patient, and that involves much more and is much more multifaceted than just surgery. Education is a large part of it, and that's going to actually define treatment success. I find that patients that understand what's going on with their body and the different mechanisms and why we're doing what we're doing is really helpful for them to for treatment compliance and for accepting different changes in therapy, which oftentimes can happen moving from one thing to the next. And the overall goal is to really improve quality of life, not necessarily to resolve pain. And so 100%. And so we talk a lot about that as well at these visits. All right, I think that's the end of my talk on this section.
Excellent. Excellent. Thanks, Dr. Tashru. Next is Dr. Ha. She is a triple boarded specialist in anesthesiology, pain medicine, and addiction medicine. And she's an assistant professor of the Department of Anesthesiology here at Stanford and the director of the Stanford Pelvic Pain Program with a clinical focus on treating both men and women suffering from pelvic floor disorders. Take it away. Thanks.
Thank you. Thanks, Dr. Tashru, for that wonderful introduction. I'm going to take more of a pain management specialist focused approach. Here are my disclosures. I'm just going to dive right in. So as Dr. Tashru was saying, there's a really broad differential diagnosis when it comes to everything that can contribute to pelvic pain. But we take all comers, men and women with all of these conditions. And we do place a little bit of a specific emphasis on nerves and musculoskeletal system, but patients can come with any combination of these diagnoses. When we look at the ISP classification for visceral pain, there's some general categorizations for persistent inflammation, vascular mechanisms, and mechanical factors, endometriosis being one of our prototypical conditions for persistent inflammation. But this is just kind of a general broad framework for how secondary visceral pain can develop. And so why am I telling you all of this? I just want to make a plug that visceral afferents are a little bit different than our peripheral nociceptors. We see the general same pathways involved in terms of the dorsal column. We have a spinal-reticular tract that is involved in transmitting the motivational and affective responses to pain, which is why we see so much of that circle of pain causing more depressed and anxious symptoms. Then we have the spinothalamic tract, and then there's a dedicated secondary somatosensory cortex for the visceral innervation. So one of the things that is very interesting about visceral afferents anywhere in the gut or the reproductive system is that most of these visceral afferents may have zero purpose in life. So 50 to 90% of them are completely turned off. So some event like, say, a viral gastroenteritis for a lot of people will be just fine. It'll be horrible, but they'll get over it. But for an unfortunate smaller percentage of folks, that viral gastroenteritis can trigger and initiate a chronic abdominal pain condition. So long after that infection is gone, these patients are still going through this visceral sensitization and experiencing pelvic pain. Some of the other factors that play into the difficulties of treating pelvic pain conditions is this concept of viscerosomatic convergence. And so our visceral and somatic nociceptors converge in the spinal cord, and there's many locations where they can cross-talk. So what does this mean? If you have a patient who's had, say, several years of interstitial cystitis and constant input into their spinal cord, they can start to develop complaints of a reflex low back pain. That doesn't mean mean that they have a primary low back pain condition, but it can look like they're starting to have pain that is spreading. So as Dr. Tasheru was mentioning, it's really important to figure out how the pain has evolved over time, because it gives us clues in terms of what all could be potential targets for modulating pain. And this is in addition to our biopsychosocial model, so heavily relying on our pain psychologists as well as our pain physical therapists, and having the patient engage in interdisciplinary strategies. So if we think that the issue is primarily visceral, which it often is for patients who have had multiple abdominal surgeries and having persistent issues despite no longer having any kind of an active surgical condition, there are several places along the sympathetic chain that we can intervene, being the superior hypogastric plexus for a lot of the reproductive organs, as well as the bladder and the rectum, or the ganglion impar, which is the very bottom of our sympathetic chain. And it's going to take afferents from the perineum or the rectal area. So these are some of the blocks that we might introduce just to cover broad areas of discomfort. So when we think that the pain is primarily visceral in nature, these are generally pretty good targets. Another thing that complicates the picture for managing pelvic pain is peripheral innervation. And so when we see a lumbar radiculopathy, for example, for a patient with low back pain, the dermatome is almost always going to be same, whether it's L4, it's always going to radiate down the leg in a certain distribution. But we can't say the same thing. So if we have a sacral radiculopathy of S2, it can affect a bunch of different nerves in a little bit of a way. And so it looks like the pain is spread all throughout the pelvis. And so it does take a little bit of extra time to tease apart what exactly may be going on. And there's a lot more anatomic variation from person to person. So this is a great example study where the investigators looked and did some differential nerve blockade and found that there were just as many people who were mostly genitofemoral dominant in terms of innervation. So skin innervation of, say, the groin and the genital area. And then there were other folks who were almost completely ilioinguinal dominant. And so when you refer a patient to our pain clinic and we start to do what we call diagnostic blocks or mapping blocks, we're really trying to figure out if there are any potential combinations of nerves where we could potentially modulate pain. In terms of if we're lucky enough to find a peripheral nerve target, then there is a whole different treatment pathway for sustaining a response, because generally, although we like to do our blocks, they tend to be short-lived. And so we can move on to radiofrequency strategies, which is just a one-time injection where we're either doing an ablation where we're actually creating a nerve lesion to sustain the pain relief response, or doing a pulse radiofrequency approach, which is more frequent in the pelvic region. And as you can see with this randomized controlled trial of pulse radiofrequency versus sham, we can see sustained reductions in our VAS scores even out to 12 weeks post-op. We have some other fancy things if patients have consistent responses to their diagnostic block, and we're really narrowing down on specific nerves. We may refer to our nerve surgery colleagues, or we may potentially consider other advanced neuromodulation techniques like spinal cord stimulation and peripheral nerve stimulation. So one of the things I do want to emphasize is that peripheral nerve stimulation has been around for a long time, but we've used mostly off-label approaches. And I would say in the last 5 years, we've seen just an explosion of peripheral nerve stimulation possibilities. So if we think that a patient has a isolated mononeuropathic pain, they're very responsive to blocks, then we may offer the option of a temporary or permanent peripheral nerve stimulation treatment. And you might be wondering, well, what does that feel like? So most of it's sensory stimulation. We do have the capacity to do some motor functioning or motor stimulation in between, but most of the time the target is to do a higher frequency sensory stimulation so that the patient is not necessarily feeling it 24/7. So some of our common targets, like Diana mentioned, we have our ultrasound guided approaches to the pudendal. And one of the things I just wanted to emphasize is that there's a lot of different locations where we can do our interventions. So again, if it seems like we're repeating some of our blocks, it may be that we're just adjusting the location to really hone in on our target. And really, any of these peripheral nerve targets are game for our neuromodulation therapies for more sustained response. And here, this is just another example of the posterior femoral cutaneous nerve that often will communicate with the pudendal nerve. So if we have patients who fail the pudendal nerve diagnostic block, we may be sending them for different nerve blocks. So the message here is, in the context of our interdisciplinary management with medications, physical therapy, cognitive behavioral therapy for managing pain and developing pain coping skills, there's a lot of different interventions that are happening in the interim. And not every patient is a great candidate for our interventions. I would say that more often than not, we want to make sure that the patient is doing the best that they can in terms of their mood. So not having like an active flare of say their depression, and able to cope with kind of the ups and downs of our interventions. Another plug too is that, endometriosis is really a full body condition. So we have seen that endometriosis can actually target or implant around different nerves and kind of mimic different other conditions like sciatica. This was an obturator nerve entrapment from a deep infiltrating endometriotic nodule. There are other neuromodulation strategies here. These are more like blanket approaches for those who live with refractory pain. Maybe they've had pain for 10 or 20 years, really running out of options. There's much less data in terms of long-term outcomes for these categories. But again, we can implant wires to pretty much cover the entire pelvic area. For our dorsal root ganglion stimulation, this would be at L1 and S2. Spinal cord stimulation, we kind of place our leads a little bit lower. But again, we're really relying on the dermatomes for peripheral innervation, as well as looking at the initial history for our mechanisms of injury. One other plug too is Dr. Tashru. She also does pelvic trigger point injections. We do ours under ultrasound guidance in a slightly different approach. So sometimes we have patients kind of handing off one versus another to figure out which approach is best in terms of providing some more sustained relief. One of the things that Dr. Tashru was mentioning was the concept of chronic overlapping pain conditions. And again, I want to put a plug in here. So we looked at patients, all patients who had abdominal pain on their initial visit and then followed up at 12 months. And there was a very high incidence, a 60% incidence of widespread chronic pain. But the encouraging news is that after 12 months, we did see that some patients, about 30%, were able to have a decrease in the spread, the global spread of their pain. But one of the things that was a very bad prognostic indicator is if the patients had widespread pain categorization or more than one chronic overlapping pain condition at their initial visit. So as a provider, if you see a patient who has pelvic pain plus, so pelvic pain plus any of these other kind of chronic pain conditions like low back pain, do not hesitate to send your patients to see a pelvic pain specialist early on. And I think I will stop at that in the interest of time because we have a case to go through.
Thank you so much for that, Dr. Ha. That was excellent. You and Dr. Tashru. I'm going to go ahead and introduce Zaina Khalil, who is our nurse practitioner extraordinaire in our department at the Pelvic Health Center. She's a board certified family nurse practitioner and also our director of clinical coordination and social media. Take it away, Zaina.
Okay, sorry. Okay, great. Hello, everyone. We are just going to jump right in. Our first case here is a 52-year-old female with pelvic pain, G3P3, 2-year history of pelvic pain. She presented with the symptoms starting back in 2020. She got a new bike, was cycling frequently, and developed UTI-like symptoms. Initially presented to her PCP with reports of urinary frequency, urgency, and dysuria, urethral pain, lower abdominal pain, and hip pain. UAs were negative. They did prescribe empiric antibiotics. She did feel better, but until she had stopped, and did a trial of Ziflucan because they thought maybe she had a yeast infection, but there was no real improvement, and was then referred to actually one of our urologists, Dr. Hano, for pelvic painful bladder syndrome, interstitial cystitis. They tried an elimination diet and some loratadine with no real improvement there. As things progressed in March 2021, so about a year later, the pain began in the left glute and sit bone regions. And so when we look back at her history, we see that she has a history of paroxysmal AFib, mitral valve prolapse, dysmenorrhea. Surgical history is for a total abdominal hysterectomy and BSO. She has a family history of ovarian cancer in her sister. Currently on estradiol 4 microgram vaginal insert. She's an engineer, only about 1 glass of wine a week, never a smoker. And these, like we mentioned, are the therapies that she's tried and failed. She, again, like I said, had a negative UA. Her post-void residual was 0 milliliters. We didn't note any significant pelvic organ prolapse on her exam, some mild vaginal atrophy. And what we did find was that she had some shortened, tightened levators, right greater than left. So here I'd ask Dr. Atashru, what would be your workup and evaluation, and what else would you like to see?
All right. So I think this is a challenging thing, because sometimes patients present with a very specific symptom and then they get kind of siloed off. For in this example, in this patient was her bladder symptoms. So because she had these bladder symptoms, she kind of went down the route for bladder evaluation, in which oftentimes, given the fact that I was able to ask her specifics about various other symptoms that she would have in conjunction with her bladder symptoms, I began to kind of unlayer sort of what this diagnosis might be. So in terms of workup evaluation, I would really just pull it back and say mainly history. I spent a lot of time on history. So, her bladder symptoms were only a small piece of the pie and the component for her overall pain story. And so that's why we kind of talked and we worked through the sort of the other body systems. And so what I would say in terms of workup, it more so was just a more detailed history from her. And so when you sort of ask for a little bit more details, the layers of the onion begin to peel back more, and then begin to sort of understand a little bit more about what her pain overall looked like. And then in general, the physical exam is super, super important here. I don't think at this point in juncture, in terms of workup, really there needs to be any sort of further evaluation. From a gynecologic standpoint, she doesn't have any gynecologic organs, right? So she doesn't have a uterus, she didn't have ovaries, fallopian tubes. So my concern about any issues regarding that were sort of minimal. And I was taking a step back and thinking, what could sort of fit into the clinical picture for bladder symptoms, her pelvic floor symptoms, how she even started having this, the incidents about her riding a bike. There's certain pain conditions in which if someone is a chronic bike rider or whatnot, they can actually have an increased risk of this syndrome. So nothing specifically extra in terms of, this would not necessarily at this juncture be an appropriate patient to order any sort of necessary extensive imaging.
Okay, so next, the patient was evaluated by pelvic floor physical therapy. So Julia, our pelvic floor physical therapist, what would you recommend as part of your regimen for this patient? Julia.
I think you're still on mute, Julia.
Yes.
Yes.
Okay, wonderful. Okay, so thank you for including me. And I didn't get to see this exact patient, but when I look at her assessment, one thing that I'm thinking is that she did have some hip pain as well. So I definitely want to screen her full musculoskeletal system. So I want to look at her low back. I want to look at her core stabilization, because we already noticed that this patient has some tightness in their pelvic floor muscles. And so I want to look at why that might be happening. Are they compensating with those muscles from something else? The other thing that was mentioned was that the patient does have some urinary frequency and urgency, even though they're voiding very nicely. So maybe talking to them about some behavioral strategies to manage some of their urgency with their bladder to help them find a little more relaxation. Perhaps the pelvic floor muscles, which are tight, are actually pushing on the bladder a little. Maybe there's some things we can do to help optimize the function of those muscles. When there are tight muscles, the first thing we want to do is teach those muscles how to lengthen properly. We always lengthen before strengthen. And so I'll go into that a little bit more in my section. And then, once we get all their muscles functioning as best as possible, I would see if their symptoms are still present at that time.
Great, thank you. So we see that the patient actually was not able to tolerate physical therapy because of the pain. So Dr. Ha, what would then be your next step?
Yeah, I think when I hear that the patient can't tolerate physical therapy, the first thing I do is probably say epic message to Julia, because she'll give me a very detailed summary of, what were the exact limitations, and that can be really helpful. A lot of times from ongoing pelvic physical therapy, the patient after time develops more proprioceptions. They're able to tell me that certain muscles are tight or certain maneuvers are limited. So I'd like to know if there's, for example, any entrance dyspareunia. What about physical therapy was difficult? Do they have any neuropathic signs? I definitely agree with Julia about doing a little bit more musculoskeletal evaluation. I'd want the patient to come back for a reevaluation, and I'm really going to hone in on that left side, especially around the sit bone, because we know there's a lot of musculoskeletal attachment. It's very easy to get a proximal hamstring tendonitis, as well as our PFCN, sciatic pudendals running around that area. So definitely trying to go back to the basics, listening again to, where is your pain currently, trying to do some Tonells and see if there's more of a neuropathic issue.
Awesome, thank you so much. Moving on, the patient ended up undergoing several trigger point injections. She had her first one in May 2021, a little bit of a flare, but then maybe some improvement. She then was started on gabapentin, 300 milligrams, only 25% improvement. In the next month, they repeated it again, good anesthetic effects, but then when they repeated it again, a couple weeks afterwards, there was no more improvement. So now we have a patient who's tried physical therapy, hasn't been able to tolerate it, really kind of not responding to trigger point injections, on gabapentin 3 times a day. And so Dr. Ha, Dr. Atashru, what would your next steps be?
Yeah, I just want to, before we go on, I just want to talk a little bit about the trigger point injection. So these are actually a procedure that I did in the office. And so on her exam, like Dr. Ha was mentioning, you really sort of have to see and hone in on what areas hurt. And a lot of times what we did is that there was definitely specific areas on her physical exam that did reproduce her pain. And so instead of kind of walking her down some other treatment option, we offered her a trigger point injection, which was relatively less risky for her and something that we could get immediate results on. And so in her case, we were thinking that it was mainly a myofascial origin of her pain symptoms. And so these multiple trigger point injections, it seemed like they would only have partial improvement of her pain symptoms, but she wasn't still getting the therapeutic response that she ideally wanted and needed. And so realized that we're sort of getting slowly crawling to some improvement, but sometimes it's always helpful to take a step back once you start down a treatment road to see if there's anything else that might be going on. So I think in this case, there is questions around, is there not only muscle involvement, but is there actual nerve involvement as well? And we oftentimes see nerve and muscle pain generators coinciding together. So I believe we ordered imaging in this case.
Dr. Ha, do you want to add anything before we see what that imaging showed?
No, I think this is our approach, conservative first, and it's like unraveling the big ball. So we always want to make sure that it's not kind of like originating from a myofascial issue. And because she's done all this work for pelvic PT and trigger point injections, we feel comfortable kind of proceeding to the next step.
Great, thank you. So here we have the patient did complete an MRI pelvis neurography, which showed increased signal along the expected course of the left pudendal nerve, just distal to where it passes between the piriformis muscle and the ischiococcygeus muscles through the greater sciatic foramen, consistent again with the left pudendal neuralgia. Otherwise, there was no increased signal or enlargement on the right. And so they proceeded and did a Botox injection and bilateral pudendal nerve block in August 2021, which did have some improvement and relaxation of the pelvic floor muscles. And what the patient reported was a knot-like pain, followed again by another Botox injection a few months later in October, which helped the gluteal muscle. And then in December, later that year, they did a left pudendal nerve block, which overall did not feel any sustained relief. So at this point, Dr. Ha, what would you recommend?
Yeah, I think at this point, that's the thing is this is like the current hot topic is like diagnostic nerve blocks, not necessarily being a good prognostic indicator for a neuromodulation therapy. So it always depends on the patient, how severe is the pain and the risk benefit balance. So if the patient is really looking for some longer term strategies, we may discuss maybe pulse rate frequency or go down the peripheral nerve stimulation pathway at this point, if she wants to explore whether those will result in some more sustained relief. Because we really wouldn't expect, if there's no steroids, if it's just local anesthetic, maybe only 4 to 6 hours of true relief or true anesthesia, and then with steroids maybe up to 24 hours. That's usually kind of the average effect. And so it's difficult for patients because a lot of times when the sedation wears off, so does the block. And so we kind of encourage our patients to do it with minimal sedation if possible. That's kind of from the pain perspective what we would offer.
Okay. Dr. Tash, did you want to add anything else, or do you want me to kind of sum it up? Okay. All right, so the next steps that were considered was maybe a left ischio-gluteal bursa versus left posterior femoral cutaneous nerve blocks. We also recommended a trial of duloxetine starting at 20 milligrams daily for 1 week with a slow increase in dose to a goal of 60 milligrams. We also really did want the patient to go back to pelvic floor PT, and we did discuss with the patient a referral to pain psychology. So if Dr. Tash or Dr. Ha want to summarize that, and maybe if we have any Q&As in the chat.
Yeah, looks like we don't have any additional questions at this time. This is really an excellent case, really summarizing. I'm really happy that we have these colleagues in our clinic, because these are very challenging patients. And as a urologist, certainly managing these patients is great to have the option of having Dr. Tashru and Dr. Ha to help with this patient. So if we didn't have any other comments on this particular case, we're going to move on to Dr. Khan just to make sure we stay on schedule. Actually, now we do have a couple of questions. We'll go ahead and move on to Dr. Khan just to make sure that we're able to get through everything. We'll definitely make sure that we answer these questions in the Q&A. So our next speaker is Dr. Michelle Khan. She's a clinical associate professor in the Department of OBGYN. She is director of the PEACH program at Stanford, which she'll talk to you a little bit more about. It's a clinic dedicated to prevention and education of anogenital cancers and HPV-associated diseases. She's also a faculty member within the Stanford LGBTQ+ health program and sees patients of any gender. Thank you, Dr. Khan.
Thank you, Dr. Anamchukwu, for that introduction. Thank you all for being here today. I'm just going to share my screen. We're going to switch gears a little bit here, and we'll be talking about cancer prevention in the lower anogenital tract. We'll be specifically talking about screening for anal cancer. And I'll tell you a little bit about the PEACH program, which is a new service at Stanford in the last year and a half. I have no financial conflicts of interest to report related to this activity. I will be discussing off-label use of screening tests, which includes mention of products that we have available in our clinics. The objectives of this talk are to discuss human papillomavirus, also known as HPV, and anal cancer epidemiology, to understand how to perform anal cancer screening and which high-risk groups to target, and to provide an overview of the Stanford PEACH program. We have a pretest poll. Okay, moving on. HPV is associated with many anogenital conditions. HPV is an 8 kilobyte virus, and it causes several different conditions along the anogenital tract and is also associated with oropharyngeal cancers. Here you can see it causes genital warts as well as lower genital tract precancers, neoplasia, as well as cancer. HPV is the most common STI in the United States, with a prevalence of 43 million and an incidence annually of about 13 million. You can see that the other STIs are not as common as HPV. We know that 80 to 90% of people will acquire HPV at some point in their lifetime. Here you can see the breakdown globally of diseases related to HPV. The most common is genital warts, which affects both males and females. The next most common is cervical cancer, which is the most common type of cancer associated with HPV. The large majority of these cases of cancer are outside of the United States or in low resource regions where there's no standardized cervical screening available. After cervical cancer, the next most common is head and neck cancers related to HPV. These are rising in incidence. After head and neck cancer, we have anal cancer. And you can see here the breakdown of anal cancers by sex assigned at birth. You can see that there are more females assigned at birth that are affected by anal cancer than males. After anal cancer, vulvar and vaginal cancers are the next most common, and the least common HPV-related cancer is penile cancer. Here you can see the breakdown by sex assigned at birth in the United States, and you can see that cervix is the most common cancer caused by HPV among people assigned female at birth, followed by anal cancer, followed by vulvar cancer, then oropharyngeal, and finally vaginal cancer, which is pretty rare. In males, you can see that the most common HPV-associated cancer is oropharyngeal, followed by anal cancer, followed by penile cancer. There is a vaccine against HPV, which I hope many of you are using in your practice. It is a 9-valent vaccine, and it protects against 9 different types of HPV. This includes 2 non-cancer causing types, type 6 and 11, which cause the majority of external genital warts. And it protects against 7 high-risk HPV types, which are the types that cause cancers. And those are 16, 18, 31, 33, 45, 52, and 58. The vaccine is approved by the Food and Drug Administration for males and females ages 9 through 45 for the prevention of cervical, vulvar, vaginal, anal, oropharyngeal, and other head and neck cancers caused by HPV. The number of doses that are given depends on the age at initiation of the first dose. So if given before age 15, it's 2 doses total. If given after the 15th birthday, then 3 doses is recommended. Well, now we're going to talk specifically about anal cancer. Anal cancer rates are rising approximately 2 to 3% per year in the United States. And over 90% of anal cancer is associated with high-risk HPV types, with HPV 16 being the heavy hitter. You can see here over the last few decades, the rates are rising, which is the light green squares. And the bottom line is mortality, which is also rising, but not quite as much as incidence. Just a brief review of terminology. Sex assigned at birth is the label of male, female, or intersex, which is given to a patient typically based on visible genitalia at birth. And gender identity is an individual's innate sense of identity as a man, woman, both, neither, or somewhere in between. Cisgender refers to a person whose gender identity aligns with the sex assigned at birth. And transgender refers to a person whose gender identity differs from the sex assigned at birth. When we talk about sexual orientation, that is a person's identity regarding their attraction to other people sexually and or romantically. So when we look at anal cancer, we see that it's more prevalent in people who are assigned female at birth than in those who are assigned male at birth. And that would be in cisgendered females. It's more common than in cisgendered males. Some risk factors for anal cancer include many risk factors that lead to HPV infection. And this includes immunosuppression, either with human immunodeficiency virus, HIV, or for other reasons. So patients who may have had a transplant or on immunosuppressive medications are at increased risk for anal cancer. Sexual gender minority status is a risk factor, particularly men who have sex with men and transgender females. Having a history of lower genital tract HSIL, which is high-grade squamous intraepithelial lesion, also known as precancer or cancer of the vulva, vagina, or cervix, is a risk factor for having anal cancer. Smoking is a risk factor. That's true for all of the lower anogenital tract cancers, and that's because smoking allows the HPV virus to persist in the body and progress. A history of anal warts has been identified as a risk factor for anal cancer. Having multiple sexual partners, which goes along with increased likelihood of getting different HPV types. And history of anal intercourse in some studies is a risk factor for anal cancer, but not in all studies. It's not a necessary occurrence in order to get anal cancer. When we look at the prevalence of anal and cervical HPV in HIV positive and HIV negative women, we see, which surprises most people, that HPV is more commonly found in the anus than in the cervix. You can see that for HIV negative as well as positive, the dark blue bars are higher, showing higher prevalence of anal HPV than cervical HPV. And you can see that for the HIV positive individuals, as their degree of immunosuppression increases, they have more likelihood of having anal and cervical HPV. This is a meta-analysis that showed all the current data on incidence rates for anal cancer, and it shows nicely what the risk groups are for anal cancer. It's broken down by sex assigned at birth, as well as HIV status, and the rates are per 100,000 person years. And just for reference, the rate of cervical cancer in the United States is 7 to 8 per 100,000 person years. And that's a cancer that we screen all people who are at risk between the ages of 21 to 25, all the way up to 65 regularly for cervical cancer. So here you can see the highest risk group for anal cancer are HIV positive individuals, and their rate is in the 80s per 100,000 for anal cancer. And you can, this stratifies by age. So you can see people who are 60 years and older have the highest risk for anal cancer, and followed by ages 45 to 59, followed by 30 to 44, and a little bit lower risk when you get down to less than 30. We know the average age of anal cancer is around age 60, so it makes sense that those at older ages are at higher risk. HIV positive, and this group that I have indicated here are specifically men who have sex with men, which is the highest risk group for anal cancer. HIV negative men who have sex, HIV negative men who have sex with men are also at increased risk for anal cancer. You can see their rates are closer to 18 to 20 per 100,000. When we look at HIV positive non-men who have sex with men, so heterosexual males or bisexual males, you can see that they have very elevated risk for anal cancer as well, as do HIV positive females. The other risk factors I mentioned earlier include a history of lower genital tract, precancer, or cancer. And of those, you can see having a history of vulvar cancer or precancer puts someone at extremely high risk of anal cancer at about 40 to 48 per 100,000. The other risk group that is at high risk are people who are immunosuppressed and have had a solid organ transplant. That's the SOTR here, over 10 years ago. So it seems to have some association with the length of the immunosuppression that increases the risk for anal cancer. So based on this data, at this point, we do not have national screening guidelines for anal cancer, who I would recommend screening based on this data that we have and on our clinic availability. I would recommend screening HIV positive individuals ages 35 and older, and HIV negative men who have sex with men starting at age 40 and older. And just remember, these are asymptomatic individuals. So people with symptoms should be evaluated, but these are people who have no symptoms, but do have risk factors for anal cancer. For immunocompromised individuals, those with a solid organ transplant greater than 10 years, and those with a history of vulvar, vaginal, or cervical cancer or vulvar vaginal HSIL, I would recommend screening at age 35 and older. And those with a history of other immunosuppressive conditions or cervical precancer starting at age 40 and older. Transgender females are a group at higher risk. I'd recommend starting at age 40 and older. And those with a prior history of anal warts or anal dysplasia, even if they are asymptomatic, I would recommend continuing screening. Some screening approaches for anal cancer include an anal cytology, which is also called an anal pap test, anal high-risk HPV testing, which is not FDA approved for this indication, but has been shown to have high sensitivity for picking up anal cancer precursors. A very cheap way to screen for anal cancer is the digital anal rectal exam, also known as the DARE, which I think we'd like to reinvigorate and get clinicians to start doing more. And this is really a screening test for anal cancer, so that if you were to feel a lump, at that point, there may be a cancer there, and they should be referred for further evaluation. I recommend anyone who has abnormalities on these screenings be referred for either the abnormal cytology, persistent HPV positivity, or an abnormal DARE. And the further evaluation is with a procedure called high-resolution anoscopy with biopsies, which is the anal equivalent of colposcopy. This is just a picture of what we use to do the anal pap and HPV testing. It's a polyester tipped swab that you insert in the anal canal about 4 centimeters and put a lot of pressure to open up the folds and get a good sample, and then put it in the liquid cytology medium and really stir it up very well in order to get all the cells off. As you start to do these, you may get some unsatisfactory samples at first, so it does require trying a few times and really beating the swab to make sure you get all the cells off. This is our typical order in the EPIC system. It's the same order that we use for cervical cytology and HPV testing, and you select anal for the location. When we're doing anal, when we're sampling the anal canal and when we're doing high resolution anoscopy, we're looking for what's called the anal squamocolumnar junction. This is morphologically analogous to the cervical transformation zone and is a region of squamous metaplasia between the rectal columnar epithelium and the anal squamous epithelium. This is the area that's most susceptible to HPV and tends to have changes and tends to be where the precancer develops. So who should you refer for high resolution anoscopy? If they're HIV positive, I would recommend referring with any cellular abnormalities, ascus or greater. If they're HIV negative, then I would recommend referring after 2 ascus or anything greater than that. Or for someone with negative pap result and HPV positive times 2 times, then they can be referred for high resolution anoscopy. Any patients with anal warts, visible perianal lesions, abnormal digital anal rectal exam, or symptoms where you've excluded other etiologies such as hemorrhoids, fissures, or sexually transmitted infections should be referred for high resolution anoscopy. There was a randomized controlled trial of whether to treat versus continue observation of people with anal
dosage of other anticholinergic medications, again, to reduce that anticholinergic burden. avoiding the use of anticholinergic medications to treat OAB in women who are over the age of 70. And so, and the American Urologic Association goes a little step further and talks about frailty, as we all know that frailty does not always correlate with age. And so really looking at the frailty status of our patients. Also considering using anticholinergic medications with low potential to cross the blood-brain barrier if they must be used in the elderly, and then using third line therapies in those that aren't interested in trying an anticholinergic. And so again, low potential across the blood-brain barrier would be medications like trospium, which are larger molecules versus oxybutynin, which is a smaller molecule. So what are the third line therapies? Well, we've got onabotulinum toxin A, which was FDA approved for idiopathic OAB in 2013. This is an office-based procedure, very well tolerated by patients. We have flexible and rigid scopes, and it's injected in the bladder in a grid-like pattern. It has high efficacy rates and low complication rates, and it's repeated on average every 6 to 9 months. We also have sacral neuromodulation. We're not 100% sure how this works or what the mechanism of action is, but the idea is that stimulating the S3 nerves helps to restore normal voiding function and may help to restore normal pelvic function, because it's not only indicated for urgency urinary incontinence, it's also indicated for urinary retention, also fecal incontinence, but it's not FDA approved for neurogenic bladder. Again, high success rates for the urinary incontinence indication, and we now have MRI conditionally safe options and 2 battery options, which are rechargeable and long life recharge free options. We have PTNS, which has been around for a while. This is a therapy where an acupuncture-like needle is placed in the ankle and stimulated for 30 minutes, and the patient comes in once a week for 12 weeks. And if they do well, then they move on to a maintenance therapy. Success rates are in the 50-60% range here, and there any serious adverse effects are unheard of here. But the biggest issue with PTNS is really for patients coming into the office once a week for 12 weeks. And it was a huge problem during COVID and when we were sheltered in place. So there are new devices that are coming out. There's this renewed interest in transcutaneous tibial nerve stimulation. And this is the Zeta sock, which is an FDA cleared wearable sock that has 2 sham controlled trials. And you can see there from the second trial that they did find significant improvement in the treatment success arm, though it's a little bit different definition of success than we use with sacral neuromodulation, and there were no serious adverse events there. There's also emerging technology of implantable tibial neuromodulation. The eCoin, which is second in the list there, was recently received its FDA approval, but this allows us to implant the stimulator so that patients can do their tibial nerve stimulation at home. So these other companies are still undergoing their pivotal trials. And then finally, there's Uro902 gene therapy. We were a site for this clinical trial. It's a plasmid vector that expresses the alpha subunit of the human big potassium channel. So essentially activation of this subunit reduces smooth muscle excitability. And so when it's overexpressed, you have bladder relaxation. And so in this initial phase 2 trial, you can see here the gray is placebo and the colored bars here are the different doses. And we can see that this is potentially a promising therapy for OAB. And so take-home messages here are really, it's important to determine the type of urinary incontinence in order to provide the proper treatment. Pelvic floor physical therapy is such an important adjunct. Patients should at least learn about bladder training, time voiding, and quick flicks, and those types of exercises to help gain better control and to really optimize any subsequent therapies that they that they receive. And then we also strongly caution against the use of anticholinergics in frail patients. The data is suggesting that there may be an association there with dementia. And then finally, in our patients, many do not come in and seek care. And when they finally do, if the first therapy doesn't work, often they will just give up. So it's really important to follow up with those patients failing therapy or dissatisfied with conservative therapy, to refer them to a specialist. All of the therapies that are FDA approved mentioned in this talk are offered at the Pelvic Health Center. So with that, I will go to the post-test question. Excellent. Very good. So I'm going to stop sharing here and go on to the next talk. And at the end of the session, we'll have a Q&A to answer any questions, and we'll start answering the questions that you have in the Q&A currently. So next up, we have we will have up, well, we've got Dr. Kavita Mishra. Got your slides up. Okay, Dr. Mishra is an assistant clinical professor in the Department of Obstetrics and Gynecology, and she has fellowship training in urogynecology and transgendered surgery and medicine. We're so excited to have her back. She did a fellowship recently at Cleveland Clinic, and I'll go ahead and pass it on to her.
Hi, everyone. Thanks for that introduction. Let me know if you can't hear me very well. So I'm going to go over uterine sparing surgeries for pelvic organ prolapse, and this will just be a brief overview of the evidence that we have and why we may not want to do a hysterectomy. So I have no relevant financial disclosures. Here's a reminder of what pelvic organ prolapse is. It's basically the descent of the anterior apical posterior vagina, or any of combination of those three. And about 12 to 19% of those who have a uterus will have a lifetime risk of undergoing pelvic organ prolapse surgery. And we know there are multiple risk factors. So the primary risk factor is actually vaginal childbirth, but secondary risk factors are things like family history of prolapse, some specific things that may happen during childbirth, like use of forceps or vacuum, having a severe perineal tear, getting older and being menopausal, smoking, connective tissue disorders, and anything that increases abdominal pressure, like constipation, coughing, lifting, and obesity. And this example here in the middle is a photo of essentially someone's cervix being the presenting part for their prolapse. And there's some other images here showing anterior prolapse, posterior vaginal prolapse, and uterine prolapse. Now, other terms you may have heard are things like cystocele, rectocele, enterocele. So those are also commonly used terms. So I wanted to go over kind of the level of supports of the vagina so we can understand why a hysterectomy might not be necessary in the first place. So the vaginal supports are primarily ligaments and connective tissue to the pelvic sidewall. And our level 1 supports, or top supports, are the uterosacral and cardinal ligaments. And these support the cervix and the upper vagina. Then we have level 2 supports, which are the attachment of the vagina to the pelvic sidewall, and specifically to something called the arcus tendineus fascia pelvis. We have fascia anteriorly and posteriorly of the vagina that also is present between the vagina and the bladder, and the vagina and the rectum. At level 3, we have support from essentially the muscles at the introitus, or the opening of the vagina. So we have our perineal body, the perineal muscles, and our levator ani muscles as well. And so these 3 levels of support are the primary areas that can be weakened and result in pelvic organ prolapse, not the weight of the uterus or anything actually anatomic about the uterus. It's all related to the vagina. So in the past, vaginal hysterectomy or hysterectomy in general was always performed when a prolapse repair was done. And part of this was to get the uterus out of the way. And part of it was that it was very routine in the past to do a hysterectomy for pretty much any GYN condition. And the pros were that we could reduce the risk of uterine cancer, and we could also stop menstruation for those who are premenopausal. And many individuals thought, well, why not? I don't really want to have periods anymore, or I am concerned about the uterine cancer risk. And so that was why it was routinely done. But the cons were that it's an invasive surgery. It adds time to the surgery. It adds recovery time as well. And most individuals report up to 3 months of fatigue after simply having a hysterectomy. So we may be doing something more invasive for something that's not exactly evidence-based. And we also know that patients want something different. There was a multi-center study of 200 individuals who had vaginal prolapse, and this was a study looking throughout the country. So had reports of people from the Northeast, South, Midwest, and West, and 36% actually desired uterine preservation during their prolapse surgery if they had a choice. And 20% preferred a hysterectomy, so a much lower percentage. But interestingly, of the people who desired uterine preservation, 21% still desired uterine preservation, even if the outcomes were inferior. And those who had a higher odds of desiring preservation were those in the Northeast, others who had some college, and individuals who felt the uterus was important to their sense of self. Recently, we have a systematic review from 2021 that looked at outcomes for prolapse surgery, whether or not a hysterectomy was performed. And this was a study looking at 12 randomized control trials, having 1,100 patients. And they found that recurrence at 1 year and re-op rates were actually the same between the 2 groups. They had the same rates of constipation, voiding dysfunction, dyspareunia, and wound infection. But those who had uterine preservation actually had less blood loss during surgery, a shorter surgery time, and overall shorter hospitalization. And the image here on the side that I'm showing you is what's called a sacrospinous hysteropexy. This is attachment of the cervix and the upper vagina to the sacrospinous ligament, which is a stable, static ligament in the pelvis, of which I think it's the coccygeus muscle that overlies. And this is a very common surgery for suspending the vagina using a vaginal approach, and it does not require the use of mesh. So we can use permanent or non-permanent stitches there. Typically, when someone does this surgery and they have a uterus in place, we either deviate the vagina to one side or the other, or try to attach the cervix to both sacrospinous ligaments. And from that systematic review, here's kind of an overall showing of the effect on recurrence rates. And so really there was no significant data showing that one was superior than the other. There were some early studies that showed that hysterectomy was better. And I would argue that that's probably because patient-reported outcomes were not as commonly used in older studies. But when we look at patient-reported outcomes, things including sensation of bulge and more objective criteria for recurrence, our newer studies show that they're essentially equal. So we still need a lot more information. We still need randomized control trials because more of them because they were variable quality in the past. And we need a lot more long-term data looking at recurrence rates 2 years, 5 years, 10 years out. And we also need to understand a little bit better what is the risk of hysterectomy in the future if someone doesn't undergo a hysterectomy at time of their prolapse surgery. Also, if we use mesh during our initial prolapse surgery with the uterus in place, what does that do in terms of affecting a hysterectomy down the road? Is it much more complicated down the road? So like I said before, we noted a preference region-wise in terms of who wanted uterine preservation. We actually have objective data showing that those who are more likely to get a hysterectomy live in the Northeast, are treated in urban and teaching hospitals, have Medicare insurance, and actually are older patients, so may want to avoid longer surgery times and more risk. And this image here is of a uterosacral suspension. It's also a native tissue surgery, meaning no mesh is used. And we can do this surgery either transabdominally or transvaginally, but typically abdominally using laparoscopy. And essentially what it's doing, it's shortening the uterosacral ligaments. That level 1 support of the upper vagina is shortened so that the uterus and upper vagina are suspended higher in the pelvis. So let's now talk about mesh-based procedures. So you've probably heard a lot about mesh, and many of the mesh kits that were used for prolapse, those have been pretty much all recalled, and that's because the complication rates with those sets were about 15%. Mesh that's placed for prolapse is typically larger pieces of mesh used in a different area from where our mid-urethral slings are placed. And our mid-urethral slings are used for stress incontinence. So oftentimes what we do in clinic is have to kind of talk about what kind of mesh are we referring to when we're saying that you can have a prolapse surgery with mesh. So typically what we're talking about is something called a sacrocolpopexy, and that's where we go transabdominally, either laparoscopically or robotically, and we place mesh on the anterior and posterior vagina and take those mesh pieces and attach them to the sacrum. You can also leave the uterus in place and festoon the mesh so that it wraps kind of around the uterus on the sides and attaches to the anterior vagina, leaving the uterus in place. We know that when individuals have a hysterectomy, they have a slightly higher chance of having a mesh complication, like an exposure of the mesh in the vagina when we do a hysterectomy at the same time. So that risk is about 5%. And we believe that when a hysterectomy is not done, that rate is lower. And we're still waiting for studies to kind of bear that out. So this is another argument for maybe doing a stronger repair, a mesh-based repair, but in somebody who wants uterine preservation, this is a very feasible option. So in conclusion, I know this was a rapid segment, but I wanted to make sure we got through all that material. What options do we have? So we can do a prolapse surgery with or without mesh. So we either native tissue repair or mesh repair called a sacrocolpopexy, and we can do those same procedures with and without hysterectomy. And we usually leave it to the patient's preference what they would like. Now, again, the hysteropexy can be performed with mesh or without. It's safe, it's per patient preference, and it looks like there's similar recurrence and reoperation rates. And we have noted anecdotally that there are a lot of patients now choosing this option. Many individuals who don't want organ removal, or unfortunately I've heard about kind of the recovery period for hysterectomy and want something brief and effective, which for this is a great option. And I'll leave it there.
Excellent talk as usual, Dr. Mishra. Thank you for that. We're gonna go ahead and go on to Dr. Gerlin next. She's a clinical professor of surgery in the Division of Colorectal Surgery here at Stanford. She's also the Director of Colorectal Surgery and Research at the Stanford Pelvic Health Center, and she's the chair of the Pelvic Floor Consortium Committee at the American Society of Colon and Rectal Surgeons. Take it away, Dr. Gerlin.
Thank you. Okay, can you see me okay over here? Just a thumbs up, maybe? Okay.
Yep, thumbs
I'm
up.
gonna say yes. Okay, great. Okay, so I'm gonna discuss a little bit. So my whole goal of this talk is to discuss the decision-making for rectal prolapse surgery. All right, I have no disclosures. And I'm going to start off showing you a little bit of an animation about how prolapse starts. So it's either poor tissue supports, or let's say from chronic straining, where the rectum infolds, it starts to kind of infold in itself. And different behaviors, or again, poor tissue supports, can make this infolding more progressive. And over time, as this rectum sort of narrows into itself, it intussuscepts, and this is the concept of intussusception. And you can see how this narrowing of the lumen of the rectal wall can occur as it progresses through the canal, and you get something called obstructed defecation syndrome. But over time, those folds can actually come all the way down to the anal canal, and they can stretch out the anal muscles. And by stretching the anal muscles and the lining being there, it can cause fecal leakage and mucus drainage. And then over time, it can also progress out of the anal muscles, and that is external rectal prolapse. So the likelihood of having multi-compartment prolapse is relatively common. And in 30% of women with rectal prolapse, they also have vaginal prolapse. And again, getting an idea about rectal prolapse, the rectal prolapse occurs when the anterior rectum invaginates and slides through the anal canal. And in this case, you see that a lot of it is anterior, and the rectum can actually hang out of the body. So when we look to see what bothers the patient most in our patient-centered experience, this is work from our own clinic, where we looked and saw that fecal incontinence and pain and discomfort were very common symptoms that brought patients in for evaluation. They also had mucus discharge and bleeding, but I want to draw your attention to obstructed defecation, which I showed you in the image, because that's really a very tricky area to deal with. So let's stop for a minute and think about obstructed defecation syndrome. And it's defined as more than 6-month duration of symptoms, straining, feelings of incomplete evacuation, hard stools, and could also be less than 3 bowel movements per week. But the pelvic floor muscles have a big impact on defecation also, and have to be kept in mind. So at rest, as each of you sit and has been sitting for a while watching the seminar, the rectal angle is maintained by the pelvic floor muscles. But during defecation and in this squatting position, those muscles will relax and allow descent of the pelvic floor and defecation. But dysnergic defecation is the inability to coordinate the abdominal and pelvic floor muscles to evacuate stool. There's also this kind of brain-gut relationship, and stress impacts the muscle relaxation and can impact evacuation. There is level 1 evidence that biofeedback is incredibly helpful for dysnergic defecation. So when they compared biofeedback versus sham versus standard, such as laxatives, this is very helpful, and our pelvic floor physical therapists really take ownership of helping with this retraining. Biofeedback has an 80% success rate. So now when we look at someone with this symptom of obstructed defecation syndrome, it could have anatomic reasons such as prolapse, and I just showed you rectal prolapse, but many of the other prolapses could also impact some of the vaginal prolapses. It could be due to a functional reason, and that's this dysnergic defecation. But of course, what happens in clinical care, it ends up being combined, and it's both with some combination of anatomic and functional features. And it's our job to sort that out. So when we looked at our first 100 multidisciplinary patients in 2018 after we opened the center, and this is our unpublished data, 94% were women, our average age was 57, and 49% of those were surgical cases, and 57% were combined. And we saw about 1/3 of them were dual prolapse, about 1/3 dual incontinence. And out of those patients who were seen, 23% saw some variation of the specialists. Now we present very much like what we're doing today. We present the cases at a monthly multidisciplinary conference that is coordinated by an advanced practitioner. And all the specialists sit in, so you're getting a feel for that now. And this multidisciplinary discussion helps to determine surgical candidacy and is key in our decision-making process. because our goals of prolapse repair are functional improvement, durability, and these are quality of life procedures. So we need a low risk profile. So when we talk about surgical options for rectal prolapse, there are over 100 that are discussed, and they're broken into two main categories of abdominal procedures or perineal. And the abdominal procedures, such as a suture rectopexy or mesh rectopexy, could be with or without resection. Their recurrence rates, or let me put it the other way, not the recurrence, but their durability rates, the likelihood of it being successful, are about 85%. But what we really want to be careful of is a 15% new onset constipation, because we'd like to avoid some additional, any other additional symptoms. Whereas the perineal procedures are tolerated in frail patients, but there's about a 20 to 40% recurrence rates. But overall, when we use the literature to guide us, they're very poor quality, underpowered studies that fail to identify the ideal procedure. So when we discuss decision-making, we have to think about this. Will an anatomic repair correct the functional complaints? Is the patient optimized? And what does that mean? Optimized from the perspective of comorbidities. Do they have rectal prolapse alone versus multi-compartment prolapse? Because I am always looking to see if there is some other form of prolapse. What is their status of pelvic floor coordination? And this is where my pelvic floor physical therapists are some of my best friends. What are their bowel movements like? And this is where the gastroenterologist and I are really focusing on optimization. Do they have any voiding dysfunction? And where are they emotionally? Are they ready for surgery? Where do they want to be with this? So this comes up with this concept of shared decision-making and identifying the patient's goals and approaching a decision with them. So in frail patients who have multiple comorbidities, we normally talk about perineal rectal prolapse procedure. And this can be added together, not me, but with my colleagues, either a vaginal suspension surgery or some sort of obliterative vaginal surgery. So we do these things together. Now, how do we define frailty? And I'm not the first one to mention frailty in these talks. Frailty is a subjective evaluation. We sometimes look at perioperative risk factors. We know that risk does not equal age, but elderly patients can be offered more durable abdominal repairs for rectal prolapse. So in the literature for the rectum versus in the vaginal literature, the definitely durability is higher with abdominal procedures. And this is a tool that we've been doing some work with called the RAI, or Risk Analysis Index. And it's a validated measure of frailty, quick and easy. And we've been using that for our patients. So showing you our own data that we have looked at, and many of the speakers on here are part of these series and have operated with me. We looked at our abdominal and perineal cases, and so our age was definitely older in the perineal group. We looked at this frailty index, and you could see that the perineal cases definitely had higher frailty rates. And that our prolapse recurrence, much like what the literature reported, is definitely higher in the perineal versus the prolapse group. But these other things, such as complications, functional improvement, and patient satisfaction, were equivalent between groups, with, again, higher recurrence rates in frail patients undergoing perineal procedures. So as far as back to surgical decision-making, when we're looking at healthy women willing to consider mesh, we talk about a ventral mesh rectopexy, and then adding on mesh if they have also vaginal prolapse, a sacral colpopexy. And this image shows you in the green is mesh along the front of the rectum, and in the red is that mesh that can be placed on the vagina. It can be done as one operation. And in a healthy woman who wants to avoid mesh, a suture rectopexy. So we don't use any mesh at that time. We use their native tissue. And then, of course, there can also be a native tissue suspension of the vagina that can be done at the same time. So when we looked at our own data, so this is from our own clinic, we looked at 70 patients, and this is published in literature, 70 patients who had rectal prolapse alone versus those who had rectal prolapse and pelvic organ prolapse. You could see that the groups were equivalent between the two, although we do a lot more of the abdominal prolapse repairs. And again, in the rectal prolapse versus the combined procedures, they were relatively equivalent in both of the groups. Now, when we looked at our 30-day complications, it was 20% for the total and a little bit higher in the combined procedure. So 14% versus 29. But when we looked at these specifics in the rectal prolapse group, we were looking at wound-related infections, wound-related issues. But in the combined groups, urinary retention and urinary tract infections were higher, which is not surprising. So in our cohort of patients, and this is from our own clinic and people who are speaking today, patients undergoing combined rectal prolapse and pelvic organ prolapse, we had a higher risk of complications than those undergoing rectal prolapse only, but most of them were minor, included urinary retention and UTIs, and there's sort of debate if this is even really considered complications. As far as recurrence rates, our results suggest that patients undergoing combined surgery versus rectal prolapse only surgery have similar rates of full thickness rectal prolapse recurrence. And in this group, patients undergoing perineal repairs had an increased risk of full thickness recurrence, but this was not a significant predictor when we controlled it for age and for a history of prior rectal prolapse repairs. So in conclusion, and my whole point today was to discuss prolapse decision-making is best managed with a multidisciplinary team so that we can really work with the patient, the physicians, and all of our team members to give the best results. Thank you.
Excellent, excellent talk, Dr. Gerlin. We're going to go ahead and move into our next case.
All right. Okay, so our second case here is another 50-year-old female with G1P1 with a long-standing history of pelvic pain, lower back pain, vaginal bulge symptoms, and reports also feeling like there's tissue coming out of her rectum. And the symptoms all started in 2010 after her first vaginal delivery. In 2016, her symptoms of the prolapse became a little bit more symptomatic, staged, and was evaluated to have a stage 2 anterior and posterior vaginal prolapse, stage 2 apical prolapse. She was trialed with a pessary number 3, but that actually worsened her pain, and then was referred to pelvic floor physical therapy. The pelvic organ prolapse symptoms did improve with PT back in 2016, but then she returned to our clinic in 2010 with worsening pain, worsening constipation, more difficulty with bowel evacuation, and now also experiencing some fecal smearing. She's evaluated by Dr. Gerlin, who just spoke, our colorectal surgeon, Dr. Hall, who also we met earlier with pain medicine, and Gloria Yi, who is also one of our pelvic floor physical therapists. When we look back at her medical history, we see that she does have a history of fibromyalgia, chronic low back pain, sciatica, myofascial pain, bilateral IT band syndrome. There's no surgery, no surgical history, and she's currently using polyethylene glycol or Miralax and Senna. There's no family history that's contributory to her symptoms. She works as a volunteer, has a couple beers a week, never been a smoker. And now we know she's tried a pessary and failed, and she only did 2 sessions of pelvic floor PT. When we do a history, we see that she also had a UA, it was negative. She had a PVR, post-void residual, of only 50 milliliters. Her vital signs are stable, abdomen is soft. On pelvic exam here, we see that she has mild atrophy, normal external genitalia. There is prolapse noted in all 3 compartments. We here see her POP-Q, which shows the anterior prolapse at level 0. And then also the stage 2 posterior at -1. Otherwise, her muscle tone in the pelvis is normal, and her anoscopy does also reveal internal rectal prolapse. So to summarize again, we have a G1P1 female with these vaginal bulge symptoms, constipation, fecal smearing, and pelvic pain. We do have a finding of a stage 2 vaginal prolapse, and we do have a finding of stage 2 pelvic organ prolapse. So we'll start with Dr. Gerland. What would your workup at this point be in your evaluation?
So I prefer to do some testing, either some anorectal manometry, MR defecography, especially in this situation of a pain, someone who has underlying pain disorders. I really want to get a great idea about what their anatomy looks like.
And Dr. Mishra, what would be your next steps? And is there anything else that you'd like to add to Dr. Gerwin's workup?
Yeah, I think I would want a better sense of their stool quality, what their straining pattern is like, see if their vaginal prolapse is at all part of that defecatory dysfunction that they're having. So that MRI defecography will be helpful for me too. And then definitely the pain evaluation. I don't like operating on somebody who is coming in with a lot of pain.
All right, thank you. So she is scheduled for an anorectal manometry and an MR defecography. Julia, what would your approach be to this patient on a pelvic floor PT exam, and what would be some of your recommendations?
Thank you. So for this patient, I love that she had normal muscle tone because that's something we don't always see. So I would particularly want to look at the patient's body mechanics. Are they doing any unnatural lifting patterns, or, what is their bowel and bladder mechanisms? Meaning, are they straining to initiate urine or bowel movements? Are they straining to complete urine or bowel movements? Sometimes patients kind of get into those habits, or in your history, you can find out that they don't like to spend a lot of time on the toilet, so they push to rush, and that would certainly contribute to maybe these symptoms of prolapse. I'd also want to look at their other musculoskeletal, like their core, their back, and just see if they're kind of hanging out in postures that might be contributing to this prolonged tension on the pelvic floor or straining on the pelvic floor.
Great, thank you so much. So here's some of the imaging that we had requested. She completed an anorectal manometry. She had a normal tensive anal sphincter pressure and good augmentation when we asked her to squeeze. However, when we asked her to push or have a propulsion, there is actually a paradoxical anal sphincter contraction, which becomes consistent with dysenergic defecation. Her sensations are otherwise normal and her reflexes are normal. And then another abnormal finding that we have with her is there's inability to expel the rectal the balloon after 2 minutes. And that's without the use of a squatty potty. We give them a second chance after that. And she is after 5 seconds, but with the assistance of the squatting stool. She then has an MR defecography, which showed grade 2 bladder descent, grade 2 uterine vaginal descent. There's also a peritoneal seal. And in the posterior compartment, there's a small anterior rectus seal, which collapses during defecation, but then otherwise, in regards to a rectal prolapse, it's only found to be an Oxford grade 3 internal rectal prolapse. So here we have some still images from the MR defecography. Unfortunately, we couldn't get the animation to work, but here we see at rest, this is the rectum full of gel. Here is the bladder. And then when we ask the patient to do a Kegel, so she's contracting, we have another image of that here. To the next here, we see as the patient is beginning to push. So this is the gel starting to come out of the rectum. And then you also kind of see the bladder here descending. And then here is at the end of evacuation. So now you see in comparison when the rectum was full of gel and now there's no more gel really in the rectum. And then you see here the bladder is also prolapsed a little bit. Anyhow, so again, back to summary: bulging symptoms, difficult evacuation, constipation, fecal smearing, and then there's also still this pelvic lower back pain. We have an internal exam of internal prolapse, but nothing that we're seeing on defecography and external rectal prolapse. But the defecography does confirm the exam findings of the stage 2 vaginal prolapse. And now we have dysenergic defecation on the anorectal manometry. So Dr. Mishra, we'll start with you. What would be your next steps in management?
Yeah, I think since they've failed physical therapy and pessary for vaginal prolapse, I think it would be reasonable, with, of course, better pain management, doing a surgical repair, and is a good candidate for hysteropexy, vaginal suspension, and vaginal repairs.
And Dr. Gerwin, what would your counseling be to the patient at this point?
So I'm big on the what bothers you the most. And I would say that if the major symptom, well, it sounds like it's pain. And in general, pain is my least predictable symptom that can be improved. If the other is obstructed defecation, Obstructive defecation success rates are at best maybe 70, more like 60 to 70%. So I would say this would be a great person not to do together, but to do separate and deal with what we definitely see, take a very cautious attempt, maybe re-engage PT again and see what's going on, because even though you failed initially, I'd like to re-engage before considering. So I am not rushing to the OR. I'm really like reevaluating for many reasons.
Excellent, thank you. So we reinitiate pelvic floor PT, and now Julia, how would you reapproach the patient?
So now that I've seen their defecography and anal rectal manometry, which hopefully I would have seen as well on my physical exam, just seeing that dysynergic defecation, how they're not using the proper mechanics for bowel movements, I would really want to optimize the way they have a bowel movement so that if they do a surgery, after that surgery, they're not continuing to strain for bowel movements. They're not continuing to put that pressure on. I would also give them techniques such as positions that maybe put the legs up or help kind of with management of gravity, or even sometimes some stuff like symptom management where like splinting might be helpful for that patient while they're building up to their surgery, so that all the things that they're doing currently don't make anything worse, that they have good strategies in place to optimize their pelvic floor muscles and also learn those techniques prior to going into the OR.
Excellent, thank you. So just another summary, what ended up happening with this patient is we did not, as Dr. Gerlin stated, that any kind of surgical repair for the rectal prolapse would not likely improve the patient's symptoms. She ultimately ended up having a hysteropexy with vaginal suspension, transvaginal approach, and a cystocele rectocele repair after she had undergone some pelvic floor PT, which had improved her pain, but she'd still been feeling those vaginal bulge symptoms, and that's why they went back and ultimately did do the pelvic organ prolapse surgery. And then she was referred to orthopedic PT to address her lumbar spine pain and lower back pain now that some of the pelvic symptoms had improved. Any questions?
Don't have any questions in QA. This is a great case and wraps things up really nicely with this section. Yeah, and thanks for everyone for sticking around. If you have any other questions, please feel free to put them in the Q&A. Otherwise, please make sure that you fill out the evaluations and let us know if this was helpful. We can certainly do more of these and also focus on topics that you might be interested in.